بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. سعيد جدا بتواجدي بينكم في هذا الملتقى الوطني العلمي المهم. A lot of things we are going to try to cover today, so I will try to be brief, but this is my conflicts. I have no financial conflicts of interest related to this topic. Okay, how do we make clinical decisions? There are several ways to making clinical decisions in clinical practice. People could base their decision on pathophysiological understanding and clinical gestalt. Others may base it on experience and previous anecdotes. And most of us would like to base our decisions based on actually valid evidence. And I'll give you a couple of examples, old and newer examples, that could highlight this. This is probably before any of you or many of you have been born, but at some stage, beta blockers were perceived as a harmful medication in patients with heart failure, and this was based on purely physiologic, biologic understanding. As it turns out, several randomized trials showed that beta blockers, in fact, reduce risk of death by about 35% in patients with heart failure. So had we relied only on physiologic understanding, we would have prevented patients from a significant benefit. A more recent example from the pandemic is the dilemma of hydroxychloroquine in COVID-19. Several in vitro studies and expert opinions, even presidents as well, have pushed to use hydroxychloroquine in clinical practice. But this is all based on just a very basic understanding of the disease. And as it turns out, several randomized controlled trials were published. They were pulled together in a meta-analysis. And it turns out that hydroxychloroquine actually causes harm in patients with COVID-19. It may increase risk of death. Now, had we used hydroxychloroquine for patients, and I know for a fact that some patients around the world have received hydroxychloroquine, that unnecessary harm with this medication that is unlikely to be beneficial. So what is EBM? Evidence-based medicine, or I'm going to refer to it as EBM from now on, is the process of utilizing research evidence to provide the optimal care for patients. And this requires two things, both, and as you see, I bolded both: clinical skills and knowing the scientific evidence related to this specific area. There are several principles of EBM, the first of which is the evidence, or what we call the evidence summary. So the time, I only have 20 minutes today, so the time is not going to allow me to talk about this in details, but I'm going to mention the quick principles for evidence summary and what we mean by that. Usually evidence summary for clinicians or people practicing in clinical areas are referred to as systematic reviews and meta-analyses that pools or combines the results across similar studies addressing one topic. Some of you may be familiar with this. This is what we call a forest plot. So as you can see in the left-hand side here, there are several studies addressing treatment for COVID-19, and the effect sizes across all those studies pulled together in this big black diamond, and this is what we call the summary estimate across all the studies. Some people get mixed up between systematic reviews and meta-analyses, but the systematic review process is the process of looking for and searching for the evidence. The meta-analysis process is the actual statistical part. And why do we rely on pooled estimates rather than individual studies? So I'll give you highlight a historical example about the use of thrombolysis or thrombolytic agents in acute myocardial infarction. So the line here in the middle is 1, means that there is no difference between the treatment. Anything on the left-hand side favors thrombolysis. Anything on the right-hand side favors no thrombolysis. So if you look at the first 3 studies published in the 1960s, before probably most of us were born, They were inconclusive with confidence intervals crossing the line of no effect. But several studies afterward, even reaching to 10 RCTs that have been published in the 1970s and 2,500 patients, you can see there's a significant benefit and reduction in risk of death. However, practice did not change for a while, and subsequent studies were done. And once we reached to 30 RCTs and 6,000 patients, the effect was very clear, very obvious. It is clearly obvious that thrombolysis reduces risk of MI. But because meta-analysis and some summary of the evidence was not used often at that time, there were 40 more RCTs enrolling 40,000 patients extra have been done on the same topic. بمعنى انه نص المرضى هذولي اللي randomized to those trials, they did not get the benefit of receiving a standard of care of thrombolysis. And practice only changed in the 1990s after, with a delay of more than 10 or even 20 years. This is why summary of the evidence or systematic reviews and meta-analysis are extremely important and increase the power and can give us important information. The second principle of EBM is the quality of evidence. And when I say quality of evidence, I refer to it as how confident are we about the results of the body of evidence. And it's very simple. It ranges anywhere between being very low confidence, so you have no clue if this treatment is effective or not, to being very highly confident and sure about the treatment. Some of you may be familiar with this traditional evidence pyramid that I personally do not like, that distribute the studies based on their structure and design. This old look to the evidence have changed since the emergence of the grade approach, which you don't need to know in details. I'm going to explain the basic principles of what grade does. Although we know most RCTs are better than observational studies, therefore quality of evidence from RCTs starts at high and observational study evidence starts at low, there are several factors that could affect our confidence in the quality of evidence of RCTs that could lower our quality of evidence. For example, if you had issues with risk of bias, your quality of or confidence will be dropped. If you had issues with other indirectness or inconsistency between studies, then your confidence could be as low as very low. So not every RCT is a good RCT, and not every RCT represents high quality evidence. So that's message number one. Similarly, for observational studies, they could start as low, but they're in certain situations, especially when there is a large treatment effect. For example, old studies on vaccination, they were observational before and after studies, but because the disease disappeared completely, the effect was extremely large, it was very difficult to attribute it to anything else. So our confidence in these estimates is high, despite the fact that these are observational studies. Therefore, when you think about the quality of evidence, you should think about it not in terms of study design alone, but this complex pyramid that you are planning to publish and I'm sharing with you should be the way to go. It utilizes the summary of the studies and then a proper assessment of the evidence, and then assigning a confidence rating to the evidence. But we learned that evidence alone is not enough, does not tell us what to do. What else do we need? We need to know what are the patient's values and preferences. And let me take you through this hypothetical example. So assume that you are dealing with a patient, an adult with atrial fibrillation. As we know, patients with atrial fibrillation are at risk of ischemic or embolic stroke. So in patients who are not taking any blood thinners or without warfarin, their baseline stroke risk, let's say, is about 12%. If they receive warfarin, you reduce this risk from 12 to 4. So you reduce it by 8% in total. However, we know warfarin is associated with risk of bleeding. And if we say the major risk of bleeding in the general population is about 3% without warfarin, would your decision to use, as a patient, to use warfarin change if the risk of bleeding was increased by 5%, or the risk of bleeding was increased by 12%, or 17%? The threshold at which the trade-off between the benefit and harm changes would affect our decision. And there is a nice study that they asked this exact question. And if I was in the theater with you, I would have asked you and asked you to show your hand. So please try to answer this question before we move to the next slide. How much increase in the risk of major bleeding would you accept and still prescribe warfarin for stroke prevention in adults with atrial fibrillation? Less than 5%, 6 to 10%, 11 to 15%, 6 to 20%, or more than 20%? Okay, I assume you answered that question. So the same question was asked to clinicians and to patients. And this study was published in BMJ in 2001, and it showed very interesting results. So in the pink columns are representing the patient responses, and the black columns represent the physician's responses. And I've highlighted the majority of the physicians' responses were accepting less than 12% increase in risk of bleeding. However, patients kept going, and the only reason they did not choose more than 22% is because the survey limit was up to 22%, because when they structured the study, nobody imagined that patients would really don't care about bleeding to that extent. So as you see here, there is a huge discrepancy between what we think as physicians is important for patients and what two patients actually value and prefer. Therefore, EBM is not complete without the patient values and preferences. So if you want to practice real evidence-based medicine, you don't need to only know the evidence and the quality of the evidence, but you also need to know how to share that with the patient and how to get their values and shared decision making. David Sackett is the person who coined the term evidence-based medicine, and followed by Gord Guyot, his mentee. But David Sackett was a full professor at McMaster University when he decided to go back to R2 or PGY2 internal medicine. And the reason is he felt that he was not good enough of a doctor. He felt that he lost some of his skills because he was spending too much time on research. So he did 1 year of senior medical resident, and this commitment shows, especially from the person who coined this term, shows that clinical expertise is also a very important component of EBM. If you don't know how to diagnose your patient, if you don't know how to proceed with the clinical evaluation, then everything you know about the evidence is useless. If you make the wrong diagnosis or you miss an important disease condition, then you won't be able to treat it. So you absolutely have to be clinically competent to be able to practice evidence-based medicine. There is no way around it. So it turns out that evidence-based medicine is more complex. If you really want, because the general understanding with people is that evidence-based medicine is simply applying just the evidence, but it's more than that. You need to have diagnostic expertise. You need to have knowledge about the disease and condition. Some people may need searching skills, critical appraisal skills, even communication skills. So many, many layers that you need to be competent at so you can properly practice evidence-based medicine. But does every clinician need to know how to do literature searches? If you ask me, the answer is no. يعني هل المتوقع من جميع الخريجين من كلية الطب أو الريزيدنسي programs أنهم يكونون competent researchers؟ الإجابة هي لا. ولكن I think, from my personal view, any person who practices clinical medicine should at least know how to assess the quality of evidence, or how to differentiate a good study from a bad study. And also, they should be able to know how to interpret the results. And more importantly, that's not enough, how to apply those results to the bedside. So if you can work and these areas as a clinician, I think it's an important skill to acquire, and this skill should start from the days of medical school and should be incorporated in the residency training program. You don't need to be a methodologist. You don't need to know how to do studies, but you absolutely need to know at least from where to get the reliable evidence if you don't have these skills. But you also have to have some understanding about what represents a good study, what represents an untrustworthy study. Now, for colleagues who are going to be future researchers إن شاء الله لزملاء المستقبل إن شاء الله الباحثين منكم, why do we do medical research? There are many reasons, and I'm trying to give you some advice and tips throughout the way. But people do it for individual goals, أهداف شخصية, self-satisfaction, gratification, awards, grants. People may do it for curiosity. You're curious about something and you want to investigate it. People want to be perfectionists. They want to, practice EBM, so they learn how to do research. Others may do it for career opportunity. Others may do it to get fame, and few may do it to get more financial advantage. But if you are doing it for the last two, then I suggest doing something else, because this is a long way and not very, very efficient goals. Other, more important reasons or goals of doing medical research is something that happens at the society level. And again, this is consistent with the 2030 vision of Kingdom Saudi Arabia to improve the population health and the quality of life. Believe it or not, countries that support research in general, specifically medical research, there is an association between better health outcomes, better education, better economy. The more scientifically advanced, the more focus on academia and research, the better the outcome for this population. الحمد لله الآن نشوف في تركيز كبير جدا القيادة الرشيدة على موضوع الأبحاث. In the future, I have no single doubt in my mind أن السعودية إن شاء الله will be على في الخارطة العالمية ولها مكانة عالمية في الأبحاث. Which takes me to the next point. Also, there is the international impact, the academic reputation. We also want to move from being a knowledge user to also knowledge generator. So generating more knowledge and research applicable to our patients is also important. Also to contribute overall to the wellness and global health. These are very important reasons for doing clinical research, and they are connected to each other. So if you decide to go in a career of research, there are a few things you have to keep in mind. In order for you to be a successful clinician scientist, I'm going to give you a few tips. The first thing you need to do is find a mentor, and not any mentor, a good mentor. And a good mentor provides resources to their mentee. They provide advice and guidance. They provide opportunity with research and grants, and they provide protection. Number two, invest in yourself, whether you invest in learning new skills or invest in improving deficiencies that you have, but you have to have a continuous plan of investing in yourself. The third is also extremely important, is how to manage your time, because balancing time in those who are clinicians and researchers could turn out to be more complex than you think. You have to balance being a clinician and a researcher, so the balance between clinical and research time. You have to have some protected time for writing. You also have your other part of your life that's outside work, which is family and personal time, which is absolutely important. If you look after yourself, then you'll be able to look after others. Also, be very patient. The research field, although it's rewarding, it may take time, and a very long time. Some studies take years to be done. You may take a long time just to be an independent researcher. So if you don't have the patience, or you expect that you will be a clinician scientist within a couple of months, then that's absolutely the wrong concept. and people who are going to go through the research path should be very patient and should be very persistent. So you have to be persistent because there will be a lot of obstacles, a lot of disappointments down the road. So if you are not persistent and patient and passionate, then guess what? You're probably going to quit and not love this field. For those, the last piece of advice for those who are interested in clinical research or being clinician scientists, I advise you all, even for faculty members who are going to be supervising junior colleagues, is to read this nice piece about becoming a successful clinician investigator written by David Sackett. Absolutely, just Google it. It's available online. This was my last slide, so thank you for listening. And again, I apologize, I'm not here with you to answer your questions, but if you have any questions, feel free to reach out to me by social media or on email. Thank you.